Hi, everyone, and again, thanks for tuning in. Just talking a little bit about my experience with HipAlign and its use in direct anterior total hips, and a little bit about my experience to date. So, so basically, here's a case study of a typical example of a patient who needs a hip replacement, and kind of walks through our steps real quick. I know we touched on a lot of these points earlier. Map out the surgical incision, the bony landmarks, basically the iliac crest. Want to make sure your pin placement is safe, away from any soft tissues, and has free mobility of the soft tissues, and two little poke holes. And that's how our sterile field is prepped and draped after we've identified that window that we need. Again, the two pins are drilled, 3.2 pins iliac crest. You want it to be away from the incision site so it doesn't impinge, primarily when you're doing the femoral steps with broaching. And then we establish that the soft tissues aren't impinging and secure the base unit. After which we get the OrthoLine monitor set up. And that's kind of an example of what it looks like in its finished product. And then we attach the device for the laser as well that goes on the inside. The inner version is generally set, but with the anterior hips, the default's 40 and 15, and you can adjust accordingly based on your preferences. And then we align the unit, register it, and we're good to go. This is our registration. Again, we've talked a little bit about this already, but basically for the pelvis, we're looking at the anterior pelvic plane. Essentially, we're getting ipsilateral and contralateral ASIS and the pubic symphysis. When we talk about the leg length, we add a fourth bony landmark. What we're doing here is putting in a pin in the proximal aspect of the femur. Essentially, it's the inferior anterior ridge of the greater trochanter, which is very palpable in any patient, regardless of the muscle's mass or size. And it's a very reproducible landmark that's not a fracture risk and far out of the way of any broaching issues. And then we register that fourth landmark as well. And then essentially we're setting up our femur to get neutral position. So we get a bullseye target. Again, we're using the HANA table. We have the boot, so you can set it up as a bullseye target at the boot. Some folks use it on the boot itself. Some use the toe, a reproducible landmark that you can get. You can set it up in a number of ways. What I've been doing is I use a clear plastic drape, and I cut out a little portion of the blue drape to expose the toe and put a bullseye on there, so it's an easy reproducible target. Again, what you're doing here is establishing your rotation, your flexion extension, your abduction adduction. By eliminating all those variables, you're going to set up true leg length measurement. As we go forward, we go ahead with our case. You can leave the base unit on. You don't have to. In this case, we were able to easily do all of our acetabular work without really taking the base unit off, but it's just as easy to take it off and put it on the back table as it is to leave it on. And then we register the base unit, and we put in our cup. Now, the advantage of this here is you're getting real-time cup navigation. And I think it actually is, in my opinion, a real asset. Many times with some of the other navigation systems or robotic systems out there, you're kind of linked into one particular placement of the cup. And as we know, sometimes that changes when you get patient anatomy or you get a different feel. And the point of cup insertion is you have a safe zone that you want to put it in, and you want to put it in the optimal cup placement and fixation point within the safe zone. So I think it's important to have the freedom of being able to adjust the cup based on the individualities of each particular case. And you're getting real-time navigation.
So basically here we're using OrthoLine and not Fluoro, and we're saying, okay, well, we think we know where the cup wants to go. We're going to put it where we think it is, and here we're going to actually navigate in real time, secure the optimal numbers as you're getting real-time feedback, and then once you're confident with that, you're going to tap it in. So it's really a pretty neat way of doing this.
And essentially when you're done with that, you get your table access and your regular. And the advantage of this is in this instance, the numbers are fairly the same. But what you'll find is when folks have a lot more pelvic tilt or inclination, you might get a different interpretation on your fluoroscopic view than HipAlign. And we have some data looking at this a little bit more, but I think in my hands at least, I think HipAlign is actually much more accurate and reproducible than using fluoroscopic guidance. So essentially we're realigning the bullseye for the leg after we put in our stem, and we find the pin. and we're able to access and measure the pin as well. And in this case, we're 0 longer, which is really what we wanted. We wanted stem to be neutral. So now we have reproduced our leg lengths to the exact preoperative measurement. And there's our postoperative radiograph, so mission accomplished. The point of this being that we could do this effectively with HipAlign, and once we get our comfort level with this, essentially eliminate fluoroscopic, certainly reduce, but the goal here is to eliminate the use of fluoroscopic guidance altogether, which has its obvious advantages we pointed out earlier. So this is my experience to date and a little bit about the timeline of OrthoLine. 2009 it was brought up primarily for total knee applications, and its technology was recognized and awarded accordingly. And these are the compliance numbers for the total knee as well as partial knee, which came out in 2016. Again, a high degree of accuracy, as we've discussed in other different webinars. And then a little bit about the total hip anterior application, 2017, for acetabular placement plus or minus 3 degrees, and leg length measurement within 2 millimeters at 97% confidence, which is better than many existing systems out there. A little bit about the results we showed earlier, surgeon data, kind of looking at the SafeZone data. And essentially what you'll find is the abduction is just simply not an issue whatsoever. And inversion is not an issue, but it's actually significant improved over fluoroscopic because of the fact that you're not getting fooled by pelvic tilt or pelvic list. And with my experience, 150 patients or so that we reviewed data on, we have a running tally on that, so there's more now. But essentially, we're looking at reduction of fluoroscopic time and how we do with navigation. And initially, when I was doing these, I was using fluoroscopy to validate HipAlign. And then as we proceeded, we found that essentially HipAlign was a way to kind of more accurately put in the cup, and fluoroscopy really didn't add as much value. And in many instances, we found that we were fooled with fluoroscopy, especially when you're looking at the obturator, and sometimes you saw a wide open obturator or an obturator silhouette. And what that really meant was that you're getting fooled in your fluoroscopic coronal plane because of pelvic tilt. And so what we found is our average abduction angle was 40, which is kind of right where we wanted it, and our average anteversion was about 13 degrees. And we found that pelvic tilt highly affected the interpretation or perception of cup anteversion when you're looking at fluoroscopic. And we found there's about 6.7 degree difference. You saw some statistical significance with those numbers. And here's a little bit of that in plot form to kind of make sense. The punchline to take away from this, and we all know this, and there's multiple papers that have looked at this over the last several years, but lordotic patients get their cups under anteverted, and kyphotic patients get their cups over anteverted. And I think with HipAlign, we're eliminating those outliers. And this is just an example of what we're seeing here and the differences of pelvic tilt and how much variation they can have on abduction to a lesser extent, but certainly on anteversion, and that's well documented. So overall, I found that fluoro time is dramatically decreased to a point where for cup navigation, I really don't need fluoro. I do one shot just to make sure that the depth of resection is appropriate. And then I get a final fluoroscopic shot for the femur just to make sure that the stem is seating appropriately. But essentially, I'm eliminating the use of real-time fluoro for navigation purposes. I found that it's much more accurate to use HipAlign for pelvic tilt factoring. And I essentially don't really use fluoro for cup placement at all. So I think HipAlign's really valuable, especially as we move towards cost control, avoiding preoperative imaging, CT, MRI, as far as cost and radiation. If we could eliminate the use of fluoroscopic guidance, that's obviously very valuable for the surgical team as well as for the patient. Cost, you're talking about all the technology in your hands in the unit. The learning curve for all of these, whether it's total knee, partial knee, or total hip, the learning curve is minimal. And I think as we really move towards more and more outpatient joints and cost containment measures, this is going to be a real powerful tool for me and for a lot of others. I think to date we've had about 75,000 of these cases put in with OrthoLine. It's FDA approved for multi-use, and remember that's all in one handheld unit, which is valuable. It's open platform, so whatever implant you'd like to use, we're not changing your technique or particular instrumentation you're using. The pin site morbidity is minimal. You're talking about a very simple 10-second registration process. You're eliminating the need for preoperative imaging, and the cut accuracy is being proven out. And we have a lot of cup data, and shortly we'll have stem data to follow that verifies this. So thank you very much for your attention.